movements, he will say that they are better. So this is a growth hormone secreting tumor. Surgery is the answer. And if you have a surgical failure, then there is no answer. Then your treatment, drug treatment is not very effective. Radiation is not very effective. So surgery is very effective. Now I would like to ask you a question. For effective surgery, what are your parameters? How do you say my surgery is effective? You just cannot go and take a biopsy, right? You think you can take a biopsy? Is it a good operation? So what are the parameters that determine a good, successful operation? And what is the modus operandi? How you achieve that target?
So we can check the IGF levels.
No, not IGF level. Now during operation, I am asking you.
Okay.
Dr. Devani is saying that you should visualize normal pituitary all around.
And if there is no protrusion of the tumor on pulse album and you are...
No. This is very not a good answer. You see, now the thing is, what is a good surgery for Cushing disease? Where you can achieve 100% results have been reported. What are the parameters? And what is that parameter is not possible in acromegaly for growth hormone tumor? Or difficult, possible, but not that possible. Because acromegaly, the tumors are soft, they are milky, you cannot remove them as a nodule like you can remove in a Cushing disease. You have to remove the tumor as a nodule. Similarly, you have to achieve a radical resection in growth hormone tumor. If you have achieved a radical and complete as a nodule, you will be able to cure that person. And then you can talk 100% and 200%. But if you have removed 50%, then you cannot talk of 100% result. So you have to know what you have to achieve. And you have to know how you have to achieve. And you have to know how you have to achieve a radical resection and a complete resection. 80% tumor you remove, he will never be cured. So you have to remove quite a beautiful resection that determines the outcome of these patients. You understand what I said?
So before we go for surgery, let's see what are our other options. Do we have any other options? Dr. Goel already said that other options are not so effective. What are those other options?
So medically can be the option of medical management is there, sir.
Like what?
Somatostatin analogs like octreotide, like bromocriptine, or pegvisomant can be, sir.
Right. So which is the most effective and what is the success rate with this kind of a regime?
Most effective is a pegvisomant with the bromocriptine regimen, sir.
What's the likely success rate?
Pegvisomant is about 90% in normalizing the hormone levels.
And how long do you have to take it?
Basically needs to be continued, sir, until
Till
surgery can be performed, or otherwise, because it basically does not.
Right. So indefinitely.
Yes, sir. Receptor antagonist.
That is one major drawback, isn't it, in medical treatment?
Deopujari, sir.
When? Go ahead.
Sir, 5 minutes, we just reached at 9. Your presentation is still remaining. Okay. So we can sum up in 5 minutes, then we can start your presentation, sir.
Fine. So when do you actually use it? What is the current indication for using medical treatment?
There has been recent publication related to use of octreotide in invasion of the cavernous sinus of the tumor. And when the invasion is big, to reduce the size of the tumor, sometimes is achieved with medical treatment. However, we know that the surgical treatment is the optimal choice, but some authors like to use medical treatment to reduce the size of the tumor that invade the cavernous sinus. And after that, they perform the surgery and they have had good outcomes on it. That's also could be a way to use it.
Any other? I think the first one you said is absolutely right. So if patient is unstable, patient is not fit for surgery, patient has a large tumor with cavernous sinus extension, you're not sure if you're going to, you will probably can tide over that period, maybe get a patient more stable before you operate. But the second most common is for some reason, if you do not see a tumor after surgery, do not see a proper target after surgery, then you will use the drug. If you think that the repeat imaging does not show any definite tumor and you do not have a radiosurgery or radiation target, then you may use the drug. Anything else we need to talk about? Well, how can you biochemically prove that you have achieved a good cure? What are the current criteria for surgery or success of the treatment? How do you assess that biochemically?
Normalization of the IGF-1 values or growth hormone level.
So IGF-1 level takes how long to come down? And the HGH level takes how long to come down?
IGF level can normalize within 3 days, 3 to 4 days.
HGH levels actually come down on the same day. So most people are taking now 6-hour sample to say that if the surgery has been successful or not. And what is the cutoff level accepted by the American Endocrinological Association ACE criteria, which are currently followed all over the world?
Less than 5 nanograms per milliliter.
No, less than 5 nanograms was in 1990.
2.3.
2.3 was in 2002. Today, what is the criteria? Today, it has to be less than 1.
Less than 1.
It has to be less than 1. For a successful surgery to be predicted immediately post-operatively, you need to have levels less than 1. What are the reasons given for not being successful, especially if you are not seeing a tumor on post-operative MRI? Last question from my side, at least.
Come on, Lakshya, Vibha.
So if there is ectopic focus in cavernous sinus.
Ectopic focus is not so common in acromegaly, in growth hormones. Anything else, Dr. Lakshya?
Not sure, sir.
Dr. Jayesh, you will answer or should I?
You please, sir. You can.
So the most common explanation given is that in many of these patients, it is more true with Cushing's, but it is also true with acromegaly. The dural biopsies have shown that there are tumor remnants, either in the sella or more commonly in the cavernous wall. And this has been given as one of the reasons why it is not so successful. And these are the kind of patients where it is more common with Cushing's, as I said, but where people are talking about radiation of the whole field rather than, only the visible tumor, especially when it is not so visible.
Right.
Or medical treatment for these kind of cases. Anybody wants to add anything, Atul?
Go ahead, sir.
Yeah, this, this dural invasion thing is a very important feature, particularly in Cushing disease. You see, when you are operating on Cushing disease, if you do a complete resection, you give new life to the patient. You completely change, cure. That word cure is used. And Cushing disease persists. Many of these patients will live 6 months or 8 months or 1 year. So there is a possibility of completely giving new life to these people, and that depends on how beautiful an operation is carried out. And in that regard, one is radical resection is one thing. And the second thing which Dr. Deopujari mentioned is about the dura of the lateral wall of the cavernous, of the medial wall of the cavernous sinus and lateral wall of the sella. This dura is very, and dural remnants in that area have been described. Even a very recent publication has been there on the dural relationship. So what I like to do is at the end of the surgery, I like to scrape off the dura lateral to the sella, and that scraping has to be quite firm scraping, and that I think may be a very key factor in affecting giving a good outcome. So it is very important for us neurosurgeons to learn how to do this operation, because it is not just doing an operation. It is because if you do half operation, it will never be effective. If you do 1/3 or 1/4 or 1/8 operation, it is not going to be effective. It has to be quite effective, radical surgery. And that in Cushing disease, in growth hormone tumor, because even in acromegaly, you can actually cure the person by your surgery. So you have to be absolute in these kind of situations.
Very, very crucial comment. So at the last, I would like to highlight that the growth hormone here is less than 7 and prolactin is 64. So there is two possibility. One is combined tumor. Sometimes, prolactin is not high, growth hormone is so much high, and prolactinoma and acromegaly would be the combined tumor. That is one, if Deopujari sir and Goel sir agree. And second, that there is a growth hormone, mild acromegaly, but with stock effect that leads to prolactin level raised up to 64. So this both can be the possibility at the end. We should think like that. Right, sir?
Yes, you cannot rule out, though I think though the HGH was not very high in this patient, the IGF-1 is fairly high.
Right.
And I feel that it is dominant, or it may be the main reason. And 64 is too low for it to call, plurihormonal tumor. So, but I think it cannot be completely ruled out. I agree, but I would go by the first thing, that it is essentially acromegaly with growth hormone tumor, and prolactin is very likely secondary.
Right. So,
sir, I would like to ask, if we've done a hormone profile for the patient, we don't have an IGF-1 level. Like in this case, the growth hormone was near normal, and the prolactin is not very high, but in the range of 60s. So would we go ahead with a medical treatment with bromocriptine, or should we go ahead with surgery, because the patient does not have any visual symptoms but acromegalic features?
Rishabh, I think when the patient has so many features which are showing that patient has hypersecretion, we really need to investigate this patient. We need to probably repeat growth hormone levels, and I think IGF levels are really crucial in clinching the diagnosis. Way back when I mean, almost 20 years ago, one of the first lessons I learned was a patient I treated for acromegaly whose growth hormone level was only 3. And we did IGF-1 levels, which we had just about started at that time. I'm talking of early 90s, and they were like 700. And that is time I have come to understand that that is probably more important. And you can get, there is a nomenclature in endocrinologist's book called burnt out acromegaly, where the patients stop growing any further after achieving a particular kind of a level. And in those cases, the IGF-1 levels also are not high. And there you can probably either treat them conservatively or medically.
Okay, thank you, sir. So we have one
Dr.
question in
Ankit
the
has
chat
asked-
box. Yeah.
Yeah, Dr. Ankit has asked to Goel sir that please tell us how will identify intraoperatively that the resection is good or complete. I think sir has already answered that you should scrap the dura at the end at the normal.
Grab the dura, and on the gland side also, usually you get a very good plane. There are very few tumors which are purely intracellular where we will not get a.
Right.
The problem comes in very large tumors where you really need to exert and you need to have a lot of experience to differentiate between normal and abnormal. And I think if you have a Cushing's or acromegaly in a patient who has gone past beyond the age of having children, you can probably take out some gland with it. You are allowed to do that.
I will just like to repeat because it is so important. And it is not only important, it is crucial and game changer. What determines radical resection? You see, in non-functioning tumor, the issue is different. In functioning tumors like Cushing and acromegaly and growth hormone secreting tumors, radical resection is the key to success and key to giving new life to the person. And acromegaly, as Risha was saying, whether we can conserve an acromegalic patient, it is not possible to conserve a person who is acromegalic and is showing on his face acromegaly. You see, it is a killer. Growth hormone tumor is a killer. It is not just face that is being affected. Whole body, he will have pain in the body. You ask him first symptom, he'll say, doctor, my whole body is paining all the time. You see, it is a killer disease and you have to treat that disease. So in effect, the Cushing disease are microadenomas. Even this tumor is a kind of a microadenoma. And microadenoma, if you see this tumor, which has been shown here, there is a beautiful plane of dissection from the tumor and the normal gland. You can see the normal gland and you can see the tumor on the image. And that differentiation of normal and abnormal is the key to success. In Cushing disease and in growth hormone tumor, that normal and abnormal and that nodule. You see, there is a very famous neurosurgeon, Oldfield, Ed Oldfield. He's he is dead now, but he introduced that we should remove Cushing disease as a nodule. And that has completely revolutionized treatment of Cushing disease. From whenever we used to talk of Cushing, nobody in the world used to talk of more than 60% cure or 65% cure. But now you can talk of 100% cure, because if you have the capability of removing it as a nodule, you see that nodule kind of resection is not possible in acromegaly, in growth hormone tumor, because these tumors are soft and milky tumors. But you first debulk and then you remove the capsule of the tumor. There is a pseudo capsule around the dome of the tumor. So you have to identify the plane and you have to remove the plane. And I have to say that it is quite easy, not easy, nothing is easy in neurosurgery, but it is possible. And to do a resection is very important. You have to learn it, and you have to learn it over a period of time, over several cases. So you have to learn this technique of radical resection.
Thank you so much, sir, for this comment. I think Deopujari sir, I think we should end this thing, and we are very grateful to both of our teacher, Goel sir and Deopujari sir, that we learn a lots of things, very crucial points of the suprasellar pathology. Now, I would like to request Dr. Deopujari sir to share his experience.
Yeah, I mean, if you can unshare, Anish, please.
Yes, sir.
I think what I have done actually is I have changed my presentation because I thought it was mainly on clinical presentations. So I have actually omitted treatment completely. But we'll see what we can do. We can talk about that as well.
We are very excited, sir. Please.
So basically what I'm going to do is just talk about a few basic things before we go into the so what is sellar suprasellar region? I think we all take it for granted, but just to define the boundaries, we are really talking about the sella, the bony and the sinus structures around the sella. We are talking about the stalk. We are talking about the diaphragma sellae. We are talking about the floor of the third ventricle, And we are also talking about the optic apparatus, which is very, very intimately related to all this. And maybe we are also talking a little bit about the cavernous sinus, though all of this is, all of these are topics by themselves. I think we need to consider this when we get a clinical case of sellar suprasellar tumor. And some of the essential things which you must understand is, what is the blood supply in this area for the optic apparatus? Where does the blood supply come from? And this becomes very, very important when you decide on what kind of surgery and where you are going to operate and what you are going to remove from where. Diaphragma sellae also is a very important concept that we know that it's a small circular fold of dura mater that forms the roof of the sella, but it may have only a small opening. It may have a large opening at times. And as Dr. Goel repeatedly reminds us, it's a very, very firm structure, and it gives us a lot of scope for manipulation and removal of pituitary tumors, even if they grow very big. Other things you must understand is the blood circulation to the optic apparatus, blood circulation to the infundibulum, and this is a very, very important concept, especially for people who are going to take up transsphenoidal surgery as one of their main interests in life. So basically, we are talking about the region above the sella with the anatomical structures of hypothalamic pituitary system and the visual pathways when we talk about this, apart from the circle of Willis, of course, which is surrounding it all over. And here we are talking mainly, as surgeons, we are talking mainly about mass lesions and occasional vascular lesions. And these can be right from the dysembryogenic origin, like craniopharyngiomas, epidermoid cysts, dermoid cysts, Rathke's cleft cysts, and rarely hamartomas and germ cell tumors. And tumors originating from suprasellar structures like the gliomas from the various parts of the brain we just talked about in this area. And of course, the skull-based meningiomas which grow into this area. And then there are some tumors which grow primarily in the suprasellar space and then probably invade the sella very, very rarely, and very few systemic diseases can also be important. We also need to be very, very careful, especially as I told you from surgical point of view, to understand what is the relationship of the lesion to the internal carotid arteries and to the circle of Willis. And here I think it helps a great deal to study your radiology properly. Apart from the tumor itself, you need to look at these things also quite well. And especially for transsphenoidal surgery, you need to know the anatomical variations of various paranasal sinuses and how the carotid artery can be sort of, traced according to those eminences. The most important visual deficit which we see in these patients with suprasellar tumor due to a sellar suprasellar, the kind of tumor which we saw today, if it was growing further, what they produce essentially is the bitemporal hemianopia, which is the type of partial blindness where vision is missing in the outer half of both the visual fields. And this is caused by lesions which are usually affecting it centrally, and from below or from above is different, but we'll just get to it in a moment. So I think as a neurosurgeon, there are several ways. If Dr. tell you 10 other types of visual field, how it is compromised, but I think you need to understand at least three major issues. That if you have an optic nerve lesion, you will have a unilateral field loss. If you have a central lesion, you will have a bitemporal hemianopia. And if you have the same size field loss, like only the right side is gone, you are going back into the optic, pathways and probably the cortical areas. And these are the various places where the optic nerve pathways and the projections and the cortex can get involved and can produce various kind of defects. And the most important reasons, as we just talked about the pituitary adenoma, the other are meningiomas and craniopharyngiomas in adults. If you are talking about children, you will find that there are several other pathologies, and as an interest, I have encountered so many of them. I'll probably show you some of them. We all think that we know all this today, but the fact is that Cushing actually talked about bitemporal hemianopia being the essential feature of pituitary adenoma more than 100 years ago. And not only did he describe that pituitary adenoma produces bitemporal hemianopia, he said that Cushing divided this already into two groups. At the time when no other studies were available, he said that bitemporal hemianopia, optic atrophy, and enlargement of the sella turcica, patient has a pituitary tumor. And usually you will have a superior quadrantanopia. He has gone that much specific. And he says that in the second group where there is bitemporal hemianopia, optic atrophy, but the sella is not enlarged and it is mainly inferior quadrantanopia, you are dealing with essentially suprasellar tumor like a craniopharyngioma. So I think these basics were understood even before we had all these digital images and all other important investigations as we have today. One of the other things which almost all old-time examiners will ask you is what is Foster-Kennedy syndrome? And if you are dealing with a skull base in anterior cranial fossa, and it is a syndrome which describes the clinical syndrome. Will anybody tell me? I already have the on your screen, so you just have to read it, I suppose. But the two essential features are ipsilateral optic nerve atrophy on the side of the lesion and contralateral papilledema, and many a times this can be associated with features of raised intracranial pressure, and occasionally it may be associated with ipsilateral anosmia as well. So let us see some of the typical examples of a pituitary tumor how do we actually look at it. So this is a gradually progressive visual loss. In fact, it went to this extent that he got his both cataracts removed before he came to us that none of this has helped. And you find that he had a temporal hemianopia, which was not recognized on earlier examination before his cataract surgery. And then they found that he had a temporal hemianopia on one side and the other side vision was fairly well deteriorated. All other signs were normal. He had this kind of a tumor. So can anybody describe this tumor on T1 and T2 weighted images for me, please? Especially the intensity changes between T1 and T2.
Yeah. Come on, Lakshya.
Sir,
Start at T1.
T1 iso intense and T2 heterogeneously hyper intense kind of a tumor with the areas
So
of
it is not hyper intense. Typically, we wish it to be hyper intense, but this is becoming hypo intense compared to T1 weighted images. And this is a red flag for many patients because this can be either due to the tumor being very containing very less fluid, that is a fibrous kind of a tumor, or second possibility,
Highly vascular.
correct. So then we look at the contrast images. What do you think now?
well encapsulated cellar and suprasellar tumor with areas of with heterogeneous contrast enhancement, and it is reaching almost third window.
Right. Very uniform upper margin of the tumor, which tells you that the diaphragm is intact in spite of the tumor being so large. And secondly, the hyperintensity of the tumor, the contrast enhancement of the tumor is not uniform. You find that the contrast enhancement is much higher at the periphery than in the center. So there is a possibility that we may have some necrotic areas within the tumor. Can you identify normal pituitary here? This was your sagittal, this is your coronal. So most of the normal pituitary, as you can see, the enhancement, it is lying at the back. And when you see your images, you find that this is a very thin line, but you will find the normal pituitary there. I can assure you that. Flare images are not so important, but sometimes you can actually see blood products within, which give you some idea if patient has had apoplexy. So when you look at the pituitary, what you look at is the on the coronal images with the cavernous sinuses and how it is looking. Do you have a kind of irregular top, or do you have a regular top? Do you have a nodules going on the sides beyond the carotid? This is what you're looking for. This tumor is becoming slightly hyperintense on T2 weighted images, so more favorable in terms of sucking the tumor out. And then you look at the normal pituitary gland, which is here, and this is the normal pituitary gland over here. So this is extremely important to know, and you can actually preserve the normal pituitary gland, whatever the size of the tumor, if you are careful looking at it. And then you also need to see the CTPNS for the obvious reasons we talked about, because an eccentric septum can misdirect you to inside that you may not follow the center of the tumor properly. That is equally important. Secondly, you must always see that the sella is large enough, the intercarotid distance is at least more than 1 centimeter before you attempt any kind of radical excision. I think some people can attempt it even with a smaller distance, but I would not recommend it to be done by people who are starting out with this kind of surgery, apart from seeing the configuration of the sella, aeration of the sella. We go to the second patient. Now this patient has presented again with a gradually progressive, but though it was progressive for almost 6 months, suddenly 1 week before that, she became very, very symptomatic for her visual problems. She was otherwise quite well. She had left hemianopia on confrontation, and all other signs were normal. Other hormones were normal, and mild hypocortisolemia, and this is the scan. I think the axial scan doesn't reveal very much, especially with such small images. But on T2 weighted images, you can actually see a fluid level here. Can you see it?
Right, sir.
Yes, sir.
And to see it better, you have these images which show you again, because the scan is done in sagittal image, you can actually see a vertical kind of a split. You can see dark part of the
Cut-off sign.
portion of the tumor here. What is it called? Did anybody say?
Yeah, Dr. Kevin Devani tell apoplexy.
Right. So this patient has developed apoplexy. That's why the patient has deteriorated rapidly over the last week or two. And this is the patient who had almost lost vision in one eye at the time of. So when you get a patient to give this kind of history, you can almost be certain that there has been an apoplexy in this patient. And after removing the tumor, in fact, within next 6 hours, she improved so much better in the eyes that she is very grateful. This is another young man. He actually presented with a sudden headache, visual blurring, and became drowsy and lethargic. So another patient who gives a similar kind of history and very acute history. Now this patient obviously from the history also has had apoplexy, right?
Apoplexy.
Everything else is normal. By the time he has reached here, he has received some steroids. He is conscious, cooperative by this time. No other signs. Again, hypocortisolemia, no other hormonal disturbance. What do you see here? What you see here is actually the tumor has stopped enhancing. And you can see hyperactivity all around with just enhancement of the surroundings. And this can happen with another kind of apoplexy, which is called ischemic apoplexy. So you can have hemorrhagic apoplexy, which is more common. Almost 75 to 80% patients develop hemorrhagic apoplexy, but about 15 to 20% people develop ischemic apoplexy. And this is a typical example of that. Now, there is some feeling these days that these patients, if they are not too bad in terms of their vision, can probably be treated medically because this will settle down, but that is a controversial kind of a sentence. Now, this is a patient who came at the age of 10 years, and this is the scan. What do you think?
That case cleft.
Now, you are not seeing the intensity of a cyst here. You are seeing a homogeneous kind of enhancement. And if I show you the picture of the patient, you will understand what we are talking about. His HGH is 106 nanograms and his IGF-1 is more than 1,000. And he is at least 1.5 feet taller than both his parents. So it unfortunately has come late, but he's presented with gigantism. And after surgery, though his jaw and face became much lower, his height is not going to reduce further. But fortunately, he has achieved a remission from his high growth hormone levels. So you need to look at patient carefully. Now, I have already put the mark upstairs. Sometimes you get a giant tumor. This is a 13-year-old girl who's come with this kind of a tumor. What would you do next? You will, of course, test the vision. This is the status of her vision. Her prolactin levels were more than 3,000. She was started on cabergoline and she was given a small dose of steroids. And you can see that within 15 days, her vision improved. You can see that one eye completely cleared up, the other eye also improved, and growth hormone levels came down from 3,000 down to 227 within a month's time. It doesn't always work because in spite of increasing dosages, it went back and she eventually required surgery. But there are many patients who respond very well and can get very good visual improvement. So currently, I think in a large prolactinoma, you usually would like to try medical treatment and see the response. What about this lesion? I'm very sorry, I have not been able to erase some of this stuff. Anybody would like to describe this?
T1 hyperintense lesion.
T1 hyperintense lesion. So that is what is important. And this highly proteinaceous cyst was a Rathke's cleft cyst presenting with visual problems. And this was successfully removed, as you can see, with a transphenodal procedure.
Sir, usually Rathke's cleft cyst would be T1 hypo and T2 hyper, right? Or
correct, but it can be of different intensities. It can be T1 hyper also if there is a high proteinaceous content. This is one thing. In Rathke's cleft cyst, you can get almost CSF-like fluid, and you can get almost colloid cyst-like fluid. So it varies from. And the colloid cyst kind of fluid cysts have a thicker membrane, like this one in particular. This was a large Rathke's cleft cyst presented with visual failure, and we could remove this, but very, very thick material inside. Another patient, this is a 33-year-old woman whose eye movements are well. She's essentially presented with insidious onset of diminution of vision, and she's mother of 3 children with the smallest child 2 years, very poor vision in the right eye, and could not chart it properly even in the left eye. And this is the kind of scan which you see. Can you see a lesion here? Hypo intense on T1 weighted images. You can see it is mixed intensity on T2 weighted images. It is not extending into sella. So that is important to see. what do you think are the possibilities and what further investigation you would do?
Dr. Anish?
So, but
Possibility, 1, 2, 3.
sir, the suprasellar location may be causing hydrocephalus, a third ventricle colloid cyst, or
No.
or
Colloid
like
cyst is
craniopharyngioma.
craniopharyngioma is one possibility. Yes,
Optic glioma.
right. So these are the two main possibilities in this patient. Optic glioma, nowadays people call it optic hypothalamic gliomas together. This is what it looks on. Flare images. You can see active hydrocephalus and you can see lesion going from suprasellar lesion into the third ventricle. This is how it enhanced. Now any further thoughts on this?
Is it optic pathway hypothalamic glioma only?
Exactly. So this turned out to be optic pathway hypothalamic. We actually went for this patient not by subfrontal route, but not to disturb the optic pathways. We went through the ventricle, decompressed this tumor, and this is a post-operative scan which shows that I was surprised to see, however, that there was calcification which we could not decipher so well on the scan. Otherwise, I would have thought of a craniopharyngioma. But the heterogeneity was probably that, though our imaging experts could not tell us about the. So you can get actually a pilocytic astrocytoma can occasionally have calcification.
Yeah.
Sir, would there be any importance for restriction, diffusion restriction in such tumors?
Absolutely. So do we have a diffusion weighted image? Unfortunately, I've forgotten to put diffusion weighted image, but there was no diffusion restriction in this lesion.
So what was the biopsy in here? What was the biopsy, sir, in this case?
Biopsy in this patient has been a low-grade glioma,
Okay.
not strictly pilocytic.
Right.
So this patient has had a partial resection, which has relieved her hydrocephalus, and thereafter she is receiving radiation.
Right.
यहाँ है ना, diffusion weighted है.
Yeah. This not non-restricted.
So any pituitary tumors would you you would have encountered having a large tumor with suprasellar extension with diffusion restrictions?
No, I cannot remember. But I have seriously not looked at diffusion restriction in pituitary tumors, I must say.
Rishabh, I think diffusion restriction usually you see either in inflammatory or very high grade necrotic area. So either there is an abscess, something like that, or very high grade tumor, which is very, very unusual there. So I don't think so. Means diffusion have so much role. Right?
That's what I also think. We don't regularly do diffusion restriction images in pituitary tumors, but maybe I would start looking at it and maybe ask it to be done.
So any fibrous tumor, high grade fibrous tumor appearing with diffusion restriction?
As I said, I do not have any idea, but if you feel that it helps, we will probably try it out in your patients. Dr. Goyal, do you use this criteria?
Sir, is called.
So now this is another patient who has come with visual failure, and this is what it looks like on MRI. What do you think? I have already written there that the child has neurofibromatosis. So that is a giveaway. And how
it is
do
very
we treat this
interesting,
patient?
To decide a particular decision, optic nerve glioma, single and multiple. So very, very important here. We can see the tumor in the chiasma with one side of optic nerve.
Correct. So how do we treat this patient? This patient I have seen, to be precise, in 1997 when she was 3 years old, and parents thought that she was not seeing so well.
So
And she had forme fruste neurofibromatosis.
can I answer, sir?
Yeah.
Yes. So what we followed in SEBGI, what our teacher thought, that if tumor is single and involving the optic nerve with vision loss, of course we should excise the optic nerve and we should completely excise the tumor with complete vision loss and if patient is blind. If it is a multiple tumor, if it is involving the chiasma, then I think it is chiasmo-hypothalamic rather than optic glioma pure. Then we should follow only chemoradiotherapy or decompression on one side if there is a bilateral partial vision loss. That we follow.
So you are absolutely right, except for one fact that the criteria differ when we talk about patients with neurofibromatosis.
Right.
In neurofibromatosis, it is very well known that tumors can even involute. And therefore, we did not treat this patient, and she is now more than 25 years old. And there has not been any growth, and the lesion has remained the same.
Okay.
This is another patient at the age of 10 years. And this tumor actually, she continued to get worse. And this patient actually had involvement of both the sides, one side more than the other. But this continued to become bigger. And this patient was treated with chemotherapy and the tumor responded quite well. Now we'll see another patient. This patient was having diminution of vision for 4 to 5 months, a 14-year-old girl, and this was the scan. So we are definitely dealing with a suprasellar kind of a tumor. Fundus was normal. There were no neurocutaneous markers. This was the hormone profile. There's some hypocortisolism. HGH levels are also low. This is the scan, CT. You can see a little bit of calcification here. You can see a cystic lesion here. This is the coronal scan. Any guesses?
Anish, Haksha, Vibha.
Looks most likely a craniopharyngioma, sir, going by the presence of calcifications. And,
You can
the
see
cystic-
some calcification in a kind of a bulky kind of a tumor. And when we did MRI, this is what we see. This is the cystic component. This is the solid component. Could still be craniopharyngioma. And then when you give, you can see this fluffy kind of a tumor, not well demarcated, not very well demarcated margins.
So tumors lies in the hypothalamus.
Correct.
Yeah, hamartoma.
Hamartoma is something which usually
Very
does
young.
not present like this and does not present with visual failure. I have not seen a single hypothalamic hamartoma presenting with visual failure. So this is the, you can see the variegated kind of appearance. So I think craniopharyngioma still remains on the card.
Yes.
Pituitary is at the bottom here, but there is a possibility that this could be a hypothalamic tumor.
Mainly pilocytic glioma, maybe possibility.
Right. So we went ahead to operate. I don't know if the video works. Actually,
It's worked
I
very,
want to.
very well, sir.
Okay. You can actually see a nodular growth coming from the visual apparatus itself. And it was multinodular kind of a thing without damaging the vasculature. It is being gradually removed. Chunks of tumor could be removed. And once you have decompressed the optic, it seems to be originating from the optic chiasm itself. Posterior, and this turned out to be actually a ganglioglioma.
Oh,
So
interesting.
this we have operated so far for optic ganglioglioma, and two of them have had conformal radiation and have responded well. One patient is just being observed, and there has been no further growth so far. This is another patient, very similar. This lady came to us with obesity and visual failure, and this also showed some calcification. You can see it is almost within the hypothalamus, and the tumor was actually surrounding the carotid artery, and this could be excised. This is the scan after 3 years follow-up when the tumor has residual tumor has remained stable, but she received radiotherapy at that time, and she's quite well. Except hormonal treatment. Tumor, I have seen the patient had no visual failure whatsoever in spite of having such a large tumor here, and therefore I actually did an intraventricular biopsy first, and this turned out to be a pilocytic astrocytoma. We did a radical resection, and the child is doing well now, about 17 years old now. And this is another rare case. So you can get all tumors, especially in children, 7-year-old, presenting mainly with visual failure, and this turned out to be a PNET, and this responded well to chemotherapy, surprisingly, after a biopsy. This is another patient who has come with visual failure, bitemporal, but not very symmetrical hemianopia. Any guesses what it is? Iso-intense on T1 weighted images. These are the T2 weighted images. Can you see the lesion here? Tenting the visual apparatus up. This is the T2 weighted image, turning hyperintense. The give way is the diffusion restriction.
This one is diffusion restriction.
So what is it?
Epidermoid cyst.
Right. So this was an epidermoid cyst. He actually got out transsphenoidally. You can see it. Removed it radically from the carotid and optic apparatus till we got a smooth arachnoid there, post-operative scan. How about this? Here I think I have already. So this is one of the tumors I have treated, typically presented with premature precocious puberty and gelastic seizures. So this is a classical hypothalamic hamartoma, and at that stage we did not have RF or anything. I managed to remove this tumor reasonably well, which has reduced his behavioral disturbances considerably and reduced his seizures also considerably. These are the operative pictures from that time. Another patient, you can see the tumor with multiple small cysts. Any guesses? About 7-year-old.
Cystic.
Anyone loud and clearly?
Pilocytic astrocytoma.
Pilocytic astrocytoma. So whenever you have a lesion which is enhancing so well, which is situated in this area, what other, especially in young children, what other possibilities exist? Give me differential diagnosis. So for enhancing lesion, essentially suprasellar, this has not gone into the cellar really. You can see a normal pituitary below. Pilocytic astrocytoma is one of hypothalamic. I mean, it could be optochiasmo hypothalamic tumor. What
Could it be
else?
germ cell tumor?
We have seen a hamartoma. Hamartoma does not enhance, typically does not enhance. You have a brightly enhancing tumor. Anything else apart from glioma?
Germinoma,
A germ cell
Can
tumor?
be there.
germinoma, germinoma.
Right. A germ cell tumor. So how would you investigate?
Serum markers.
CSF markers.
Beta
Right.
FPG.
So serum markers were negative in this patient. Rather than doing a lumbar puncture, because the ventricles were large, we went and we did a biopsy and did a ventricular CSF. And this was a germ cell tumor, and you can see in 3 months the tumor has disappeared. It was so chemosensitive. Another patient. This is the scan of this same patient after 3 months of chemotherapy, 3 shots of chemotherapy. This is another patient which was again a germinoma, which was this patient actually presented with cachexia, and we thought it would be hypothalamic glioma. This patient did not have hydrocephalus, so I had to go subfrontal to take a biopsy of this tumor, and as the frozen section showed germinoma, we did not go for any further surgery because some of the tumors of they are usually of hypothalamus midbrain kind of a tumor which present with cachexia, and there the outcome is usually not very good. But this germinoma responded again very well to chemotherapy, and patient has done quite well. How about this? This is an adult. This is a 49-year-old lady who has presented again with blindness in one eye, now diminution of vision in the other eye.
Look at bone.
Sorry?
No. I'm telling them, giving the hint
Ah.
that look at the bone.
Meningioma.
So meningioma is the second most common tumor in adults, and just to top it, I think you've got a very nice hyperostosis to give you further clue apart from its proper contour, which you can see here. CT scan shows a nice hyperostosis. This one.
Also meningioma.
Also,
So there is a controversy for this kind of tumor now. How to operate on these patients? Dr. Jayesh will tell us, or one of the student panelists will tell us.
Yeah.
Endoscopy versus open craniotomy and
Yeah. That is,
Sir, Atul is still there, or
Both. We can do both approach, same setting. We can go intranasally and also by perional.
question is when open, when endoscopic. That is
Correct.
what controversy.
depends on the extension. So from the midline, if it is going more laterally, then craniotomy would be a better idea.
so
Could
that
this
is
be
one
done with an
criteria, the lateral extension. If it is crossing the optic nerve, you will not go endonasal.
Mhm.
Second is how well your sphenoid sinus is aerated. What else?
The sella is wide enough.
Sella is wide enough. Number 3, yes. So the ICA intercarotid distance should be about 12 millimeters. That is the criteria which has been put by Dr. Shekhar for this kind of determination. One more factor has been added by this group from California. They are saying that you should also look at the angle of the anterior cranial fossa to the sella. A deepened sella with tuberculum angle of less than 35 favors endonasal removal because you cannot see the tumor which is originating just below the planum into the anterior wall of the sella. Sometimes the tumor does flow over and you need to remove that kind of a tumor. So these are the 3 or 4
One-
factors which
One
decide.
point just would like to add, sir. If in T2 weighted, we can see that it is a very fibrous tumor sometimes. And if we are in the beginner stage, definitely
I think hyperostosis, fibrous tumors can be probably taken as a criteria not to go
kind
for
of
it.
related to-
And another one will be a dural tail, which goes much
Right.
beyond. This is a post-op. This went off quite well. Now this one. So this is our criteria today. I mean, if I get this kind of a tumor, you can see a steep sella. This tumor we did endonasal, and a relatively small tumor. And this is a tumor which is going beyond the carotid, which is going beyond the optic nerve. You can actually see that the anterior cerebral arteries were the carotid bifurcation was actually within the tumor. So this we decided to go terional to excise this
just
tumor.
for resident, the recurrent tumor, always try to go for cranial, because in recurrence there is a fibrosis and the adventitia of the vessel will involve with the tumor. Very difficult to separate from endonasally. Agree, sir?
Yeah. Now, there are some tumors which can again cause you a lot of confusion. This is one of them. What is it?
Sir, आपने सब में diagnosis
Craniopharyngioma.
This is clearly a craniopharyngioma, but what kind of craniopharyngioma?
That is very
Cystic. So adamantinoma, sir, it's cystic.
Right. So it is a cystic craniopharyngioma. And is it essentially suprasellar or intraventricular?
Intraventricular.
Left.
Suprasellar.
It's within the third ventricle.
Though it is in the third ventricle, it is coming into the suprasellar region and it is essentially a cystic tumor. So we actually did this endonasal, as you can see from the fat which is put here. So it is not the upper margin. Where the lower margin of the tumor is, I think determines where you get it out from.
Yeah, and sometimes retrochiasmatic tumor, you can say post-infundibular tumor is very difficult to excise from endonasally in craniopharyngiomas, right?
Correct. So a corridor in front of the pituitary, I think, is a very good indication to go for this kind of a tumor. This is another predominantly cystic craniopharyngioma, as you can see with this calcification, etc. So currently, I actually go intraventricular, drain the cyst, and then remove the solid component from nasal approach. So I am doing a two-stage approach for this kind of tumors. This is a 5 years follow-up of the same patient, and it has remained well.
Sir, in such kind of cases which you showed, the adamantinous craniopharyngioma, suprasellar cystic lesion, do you advocate going transventricular, aspirating the cyst and injecting bleomycin into it?
I have done this in a few patients, almost 7 patients I have done, and actually yesterday only I operated on one craniopharyngioma where I'm going to do that. But I do it mainly for patients who are otherwise have had previous surgeries. Primary upfront, I will do intracystic therapy only for patients under the age of 5, where we do not give radiation. And where you do not, and if they are hormonally intact, then I do aspiration and then I do this installation, and till they become about 7 years old, after which I would either try radical excision, or if they have not grown at all, then I would ask for a radiation treatment, because this is a definitive treatment. I am something I am not sure of.
Yeah.
I think it is a treatment which is very important in very young children who come with predominantly cystic tumor, and where you need not do a very major surgery. They respond very well to cyst aspiration, and the cyst remains dormant for somewhere between 2 to 3 years. That has been my experience of about 7 cases.
Probably recurrent craniopharyngoma,
Yeah.
which is third time coming and you have no, I think so, that then it will work maybe.
Correct. This also gives you one major advantage, that when these patients go for surgery, they do not have a large cyst. You know, even radiotherapists will tell you that they have to keep on changing their plan in patients who have got cystic craniopharyngioma, because cyst very rapidly changes size. One advantage that happens after installation of alpha interferon currently, earlier we have used bleomycin in 2 patients, but it is toxic, so we don't use it anymore. Is that the most of the recurrences then become solid and they are thick walled. So they are either good for good radiotherapy targets, or they are good for even surgical excision if you can manage. This is a young patient who has presented with this scan, iso-intense even on T2 weighted images. What do you think?
Still be hypothalamic.
Sorry?
So contrast enhancement.
Contrast enhancement here. It is not at all enhancing.
Hypothalamic hamartoma.
I think that is T1, right, sir? That image is T1.
This image is T1.
Yeah.
This image is T2. This image is contrast.
Okay.
Actually, I thought this would be a great sometimes the non-enhancement is something which has to enhance somewhere. The fact that there was no calcium and there was no enhancement at all, we were not sure what we were dealing with. We also thought of Rathke's cleft cyst, to tell you frankly, but this turned out to be an arachnoid cyst.
But
and this has been very nicely
tackled
with
in T2 weighted, it is completely,
So that is something which I am still not able to explain, and our radiologist is not able to explain, but this was just clear CSF, nothing else whatsoever.
Oh my God.
So sometimes a static CSF can look a little darker. That is what
when we can see in the first floor that there is a kind of heterogeneous.
So this heterogeneity, actually, this is a very good point which you have come out with. I did not keep the video in this because essentially I thought I will just discuss the plethora of cases rather than surgical technique. But this was actually the stalk of the patient, stalk of the pituitary. And I had to go on either side to get the, do a marsupialization of this cyst. So I have marsupialized the cyst behind the infundibulum.
So it means maybe
understand that
because of thick content of the CSF, maybe some, that would be the reason of this.
Yeah, but I mean, this was a googly. I didn't anticipate it, and I'm really surprised that the wall has not shown any cuboidal epithelium. I seriously expected this to be a Rathke's cleft cyst, because there also you can get sometimes very clean fluid.
Right. Very interesting.
Now, this is another thing. This patient has a suprasellar tumor, and he's presented not only with visual deficit, but also 6 nerve paresis. And if you look at the CT images, what do you find?
Erosion.
You find a lot of bony erosion. And you can see that the whole diaphragma sellae has been eroded, top of the clivus is eroded. So the diagnosis?
Chordoma.
Clavichordoma.
Right. And most likely diagnosis, differential diagnosis is such issues. I have been fooled by it a few times.
Giant cell tumor.
Sorry?
Giant tumor.
Giant cell tumor is a small possibility. Giant pituitary adenoma, especially prolactinomas, I have seen they can invade the bone very
Sir,
badly.
what is the age of this patient?
This patient
Adult
was
or-
about 26.
Okay, means adult patient, right?
So
No, it's
even
not
we have
small.
seen such kind of a case recently, and the reason why I kept on asking about diffusion restriction was such kind of case had a diffusion restriction in our.
Sphenoid sphenoid mucocele you found.
No, sir. Diffusion restriction with the destruction of the sella and the sphenoid sinus, and similar kind of picture on the scan.
And what did it turn out to be?
It has turned out to be pituitary adenoma on the frozen, sir. As of now, we are waiting for the final report.
Prolactin levels?
But the prolactin levels were not very high, sir. They were 60 for this level, and the patient also had low cortisol.
Okay. Most of the bony eroding tumors I have seen. Is Dr. Goel there? I cannot see it on my screen.
Sir, it's not there.
He's not there.
Right.
Most of the cases I have seen with extensive bone erosion with pituitary tumors have really been prolactinoma. So please check with double dilution and whatever else.
Invasive pituitary adenoma is very
Yeah.
common.
This is another chordoma for you. You can see almost amputation of the top of the clivus with the tumor. This patient also presented with visual deficit and isolated 6-nerve paresis. So that is a giveaway many a times apart from, and I think you must do a CT in these patients to make sure. I will not take you through this video, but we could manage to remove the tumor and save the pituitary stalk, etc. So I think we have seen a variety of lesions. If you really have a case like I had for my MCH exit exam, I had a case of suprasellar tumor as a long case, and then it becomes very difficult. So you better know what kind of defect you can get in optic tracts and how is the configuration of optic fibers. It is beautifully described in many books. So I would strongly recommend you. I'll be happy with optic nerve involvement, chiasm involvement, and optic tract involvement if you can differentiate that much, but some people might insist more than that. And the location and the tumor and your surgical approach becomes extremely important. And though the endonasal approach is increasing, I think we discussed in a few cases where you should avoid it and where you should take it. And this debate is maximally used for meningiomas, where we still do not know what is the best way to do it. I think like we know for sure today that pituitary tumors and many of the chordomas which are strictly midline should be tackled endonasally. In craniopharyngiomas, it is probably equally divided. Some can be done better than endonasal approach than the transcranial approach, but transcranial approach still remains a favorite approach. In meningiomas, I think predominantly the transcranial approach, very little endonasal approach, but there are more and more indications emerging for this. So this slide will keep on changing as our technology keeps on improving for and expertise keeps on improving for these kind of surgeries. I think I'll stop here. Thank you.
Thank you, sir.
So before we close, sir, there was one very interesting question asked by Dr. Achal that with optic nerve glioma in pediatric patient who is unable to appreciate some diminution of vision but has torticollis and squint to compensate, and radiology showing unilateral optic nerve glioma extending posteriorly up to chiasma in case of NF2. Should we, neurofibromatosis, should we wait or watch? The same thing we discussed.
So I think the most important point you said at the end, in neurofibroma patient, I would still be conservative. I would still think of, unless the patient has a very bad proptosis and the eye is at risk because of the mechanical reason, I am not very keen to operate on a neurofibromatosis patient. If this is a patient without neurofibromatosis, I will amputate the optic nerve at the level of chiasm, and I have actually done a removal of the globe as well as removal of the whole nerve. I have done, but only 2 children I have been able to do this kind of surgery. because most of the patients who have preserved vision, you do not want to do this kind of surgery. And surprisingly, in low-grade glioma optic chemotherapy has been fairly successful. So surgery, unless you really have very strict criteria, unilateral optic nerve glioma, stopping short of the chiasm, presenting with proptosis apart and is completely blind. I think if these criteria are fulfilled, then you may consider radical surgery. Dr. Sardana has disappeared after asking the question.
No, I think, sir, his because of internet connection and probably something he would have gotten
But
locked
these
out.
are my criteria for using that. There is also a little bit of controversy as to what is better, either radiation or chemotherapy. I think in neurofibromatosis and non-neurofibromatosis cases, the chemosensitivity is different. And therefore, Jayesh, you have anything to comment on this one?
No, sir. I completely agree. Completely agree.
So I think you have to treat NF and non-NF patients separately, and you have to really think of radical surgery only with these 3 or 4 criteria.
Right.
Actually, sir, I have a question.
Yes, Achal, speak loudly.
Sir, my basic concern was that pediatric patients are not able to appreciate that.
Achal, we are not able to hear you. You can write it down in the chat box. We can read it.
Any other questions from the panel who was presenting, Anish, Lakshya, Vibha, or anyone from the audience who would like to ask anything before we conclude the session?
Okay, fine, Rishabh. I think. So it was, sir, we are so grateful to you. We have learned a lot. It was a series of rare, unusual, and very interesting cases. And at the end, we have, we have shown complete picture of suprasellar, clinically and some extent radiologically, differential diagnosis, and we also you cleared that should go for endoscopy, should we go for transcranial. And thank you so much for your time, sir.
Most welcome. I'm personally not very happy with my presentation because I was a little bit confused as to what you would be interested in.
But sir, I think it was what was needed. It was you have given more than that.
Yes, sir. Actually, sir, I think the students have benefited more with what you had presented rather than what you would have hoped it to be.
Sir, Achal has right that comment. My basic question was that pediatric patients are not able to appreciate diminution of vision.
Correct.
And vision is one of the most important criteria in deciding management whether.
Absolutely right. So I think it is used by many people as one of the criteria. And I think a child above 3 years of age, you can probably interpret VEP reasonably well.
Right.
That can be used as a criteria.
Right. Thank you, sir. We can have one photos and then we can.
Yeah.
Complete.
Yes, sir. I would request all the participants in the chat box, if they can just switch on the videos, we'll have a short picture